Lecture series, and it is going to be the chapter 13, retinal vascular diseases. So now we are going to start discuss about the retina, and now we are going to discuss mostly about the diabetic retinopathy in this chapter. First, so retinal circulation. Arterial system. Central retinal artery and end artery enters the optic nerve approximately 1 centimeter behind the globe. It is composed of three anatomical layers. The intima, the innermost, is composed of a single layer of endothelium resting on a collagenous zone. The internal elastic lamina separates the intima from the media. The media consists of mainly of the smooth muscle. The adventitia is the outermost and is composed of the loose connective tissue. So basically, the retinal artery pierces the optic nerve 1 centimeter behind the. So this is a globe, and it basically has a three parts, three layers. So there is an intima, media, and adventitia. And between the media and intima, there is an internal elastic lamina as well. So, retinal arterioles arises from the central retinal artery. The walls contain the smooth muscle, but in contrast to arteries, the internal elastic lamina is discontinuous. So, in contrast to central retinal artery, the retinal arterioles have a internal elastic lamina which is discontinuous. Capillaries. Retinal capillaries supply the inner two-thirds of the retina, with the outer third being supplied by the choriocapillaries. So, you know that we have an inner two-third and outer one-third. The outer one-third being supplied by the choriocapillaries, whereas inner two-third being supplied by the central retinal arteries, and which basically retinal capillaries. So what is the outer one-third layer? The outer one-third layer is basically up till the level of the outer plexiform layer. The inner capillary plexus is located in the ganglion cell layer, while the outer plexus in the inner nuclear layer. Capillary free zone is around are present around arterioles and at the foveal avascular zone. Retinal capillaries are devoid of the smooth muscle and elastic tissue. Their wall consists of the following. So retina has almost the 10 layers. So first layer is basically RPE. Next there is a photoreceptor layer. Then there is an outer nuclear layer. Then there is an outer nuclear layer. Then there is an outer plexiform layer. Then there is a inner nuclear layer. Then there is an inner plexiform layer. Then there is an ganglion cell layer. Then there is a nerve fiber layer, and then there is an external limiting membrane, internal limiting membrane. So these are almost the 10 layers of the retina. So the first plexus is basically present in the ganglion. So basically the capillaries have the two type of plexus, the outer plexus and the inner plexus. The outer plexus lies in the inner nuclear layer, and the inner nuclear layer and the ganglions and inner plexus and the ganglion cell layer. And at the fovea, basically it is devoid of the capillaries, so it is known as a foveal avascular zone. So capillaries consist of endothelium, which forms a single layer on the basement membrane and are linked by the tight junction that forms the inner blood retinal barrier. Very important though, what is the inner blood retinal barrier? It is basically formed by the endothelial cells of the capillaries. So capillaries are having an endothelial cells, and they are bound together by a tight junctions which is forming the inner blood retinal barrier. After that, there is a basement membrane lies beneath the endothelium with an outer basal lamina enclosing the pericyte. Then it is an outer basal lamina which has pericyte. So pericyte lies external to the endothelial cells and have multiple pseudopoidal processes that envelops the capillaries. Pericytes have the contractile properties and are thought to participate in autoregulation of the microvascular circulation. Venous system. Retinal venules and vein drain blood from the capillaries. Small venules are larger than capillaries but have similar structure. Larger venules contain a smooth muscle and merge to form vein. Veins contain a small amount of smooth muscle and elastic tissue in their wall and are relatively distensible. So the venous system more have the elastic tissue in them. That is why they are easily distensible. Their diameter gradually enlarges as they pass posteriorly towards the central retinal vein. So you can see this is a normal retinal capillary bed. A is showing a periarteriolar capillary free zone. So this is a periarticular and around it is a free zone of capillaries. Flat preparation of injected retina. B is showing endothelial cells with elongated nuclei and pericytes with rounded nuclei. So the elongated nuclei are endothelium, whereas rounded nuclei of the pericytes. So now we are going to discuss very important topic of all the retina. It's the diabetic retinopathy. Introduction. Diabetes is a major concern for the healthcare system throughout the world. The prevalence of diabetes is relentlessly increasing, particularly in working age adults. Approximately one half of the individual with diabetes will develop retinopathy in times, with diabetic macular edema being the most common cause of visual loss. So basically, the diabetic macular edema causes the visual loss. Ophthalmic complications of the diabetes. So there are some complication that is associated with diabetes. They can be common, uncommon, and rare. Common consists of retinopathy, which consists of a diabetic macular edema, macular ischemia, and sequelae arising from the retinal ischemia, retinal new vessels, vitreous hemorrhage, and tractional retinal detachment. So what is included in very important is a retinopathy, which includes the diabetic macular edema. There can be macular ischemia as well. There can be retinal ischemia, which can lead to retinal new vessel, vitreous hemorrhage, and tractional retinal detachment as well. Iridopathy, which is having a minor iris transillumination effect. They can have a unstable refraction as well. Uncommon ophthalmic associations are the patient may complain of recurrent styes, xanthelasma, accelerated age-related cataract, neovascular glaucoma, ocular motor nerve palsies, reduced corneal sensitivity. Rare association with diabetes include papillopathy, um, um, pupillary light near dissociation, and Wolfram syndrome, progressive optic atrophy, and multiple neurological and systemic abnormalities, acute onset cataract, and rhino-orbital mucormycosis. So, what is the prevalence of the diabetes? The reported prevalence of diabetic retinopathy in individual with diabetes varies substantially amongst studies and even among the contemporary population in the same country, but is probably around 40%. So a patient who have a diabetes, about 40% of them will have some kind of a diabetic retinopathy. It is more common in type 1 diabetes than in type 2, and sight threatening disease is present in up to 10%, and 10% of the patient will have a sight threatening disease. Proliferative diabetic retinopathy, PDR, in which the new vessels are being formed, affect about 5 to 10% of the diabetic population. So it is also 10% is having a PDR. Type 1 diabetes had a particular risk with an incidence of up to 90% of the 30 years. So a patient who is on having a type 1 diabetes, then most of the time 90% after 30 year will have a diabetic retinopathy. So what are the risk factors? So duration of diabetes, poor control of diabetes, pregnancy, hypertension, nephropathy, and other risk factors. So, duration of the diabetes is the most important risk factor in patient diagnosed with diabetes before the age of 30 years. The incidence of diabetic retinopathy after 10 years is 50% and 30 years 90%. So, talking about the type 1 diabetes, if the patient have been diagnosed diabetes less than 30 years, so what happens is that after 10 years, 50% of the patient will have a diabetic retinopathy, and after 30 years, the 90% of the patient will have a diabetic retinopathy. Diabetic retinopathy rarely develops within 5 years of onset of diabetes or before puberty, but about 5% of type 2 diabetes have a diabetic retinopathy at presentation. So, diabetic retinopathy do not develop before puberty or 5 years after the onset of diabetes, but 5% of the patients who have a type 2 diabetes present with the diabetic retinopathy. It appears that duration is a strong predictor for proliferative disease than for maculopathy. So, it is basically duration is more for the proliferative disease. Poor control of diabetes, the diabetic control and complication trial, DCCT, shows that a tight blood glucose control, particularly when instituted early, can prevent or delay the development or progression of diabetic retinopathy, subsequently confirmed by the United Kingdom Prospective Disease (UKPD). Yes, so there have been two studies that have been conducted, DCCT and UKPDS. So what is they have been noticed that if you tightly control the blood glucose level, it can either delay the development or progression of diabetic retinopathy, and this is also confirmed by the United Kingdom prospective diabetes study. However, sudden improvement in control may be associated with progression of retinopathy in a short term. Type 1 diabetes patient appears to obtain greater benefit from the good control than type 2s. So, in a start, basically, when the tight blood glucose has been done, there will be the increase in a diabetic retinopathy. Raised HbA1c is associated with increased risk of proliferative disease, so the aim should be HbA1c value of 6 to 7%, 8% in frail elderly patient. By decreasing the HbA by 1%, the microvascular complication can be reduced by one third. So HbA1c is also a strong predictor of PDR, and if you control the HbA1c for at the level of 5 to 6 to 7%, you can control the diabetes by about one third. So pregnancy is sometimes associated with rapid progression of diabetic retinopathy. Predicting factors include the greater pre-pregnancy severity of retinopathy, poor pregnancy control of diabetes, control extended too rapidly during the early stage of pregnancy, and pre-eclampsia. So pregnancy can be associated with diabetic retinopathy, so that there can be like a severity of retinopathy. There can be poor pregnancy control of diabetes. There can be preeclampsia. There can be that if so these are all the risk factors for having a diabetic retinopathy, and if the control is exerted too rapidly during the early stage of pregnancy. The risk of progression is related to the severity of the diabetic retinopathy in the first trimester. So how much severe the diabetic retinopathy in the first trimester leads to the risk for progression. Approximately 5% with mild diabetic retinopathy, and a third of those with mild diabetic retinopathy will progress to PDR during pregnancy. So 5% of the patient with mild and about a third with the moderate will progress to PDR during pregnancy. If a substantial diabetic retinopathy is present, the frequency of review should reflect individual risk and can be up to monthly. Diabetic macular edema usually resolves spontaneously after pregnancy and need not to be treated if developed in late pregnancy. So diabetic macular edema resolves after the pregnancy. Hypertension is very common in patient with the type 2 diabetes and should be rigorously controlled less than 140 by 80. Tight control appears to be particularly beneficial in type 2 diabetes with maculopathy. So it is one of the so patient who have diabetes and also have an hypertension, so you should control the hypertension as well, otherwise it will become the risk factor for diabetic retinopathy as well, and it is also beneficial in controlling the maculopathy. The cardiovascular diseases and previous strokes are also predictive. Nephropathy severe is associated with worsening of TR. Conversely, treatment of renal disease, for example, a renal transplantation, may be associated with improvement of retinopathy and a better response to photocoagulation. So, nephropathy is also a case of increases the diabetic retinopathy. Other risk factors include hyperlipidemia, smoking, cataract surgery, obesity, and anemia. Patient with diabetes needs to undergo regular retinal screening. So what is the pathogenesis of diabetic retinopathy? So basically in diabetic retinopathy, the microvessels are being affected by the levels of sugar. So it is a microangiopathic disease. Diabetic retinopathy is predominantly a microangiopathy in which small blood vessels are particularly vulnerable to damage from the high glucose level. Direct hyperglycemic effect on retinal cells are also likely to play a role. Many angiogenic stimulators and inhibitors have been identified. Vascular endothelial growth factors appear to be of particular importance in the former category. So classification. So there are multiple classification. One is ETDRS and classification of diabetic retinopathy. The classification used in the early treatment diabetic retinopathy study, the modified Early House classification is widely used international, and now it is being widely used. An abbreviation version is set on in table in conjunction with the medical management guideline. The following descriptive categories are also in a widespread use in a clinical practice. So in clinical practice, we can do background diabetic retinopathy, diabetic maculopathy, pre-proliferative diabetic retinopathy, PDR, and advanced diabetic eye disease. So what is a background diabetic retinopathy? Background diabetic retinopathy is characterized by microaneurysm, dot plot hemorrhages, and exudate. So nothing more severe, just a microaneurysm, hemorrhage, dot plot, and exudate. These are generally the early sign of diabetic retinopathy and persist as more advanced lesion appear. Next is a diabetic retinopathy, where there is a macula is involved. There can be macular ischemia, edema, and other vision threatening lesions. Diabetic macular pathy strictly refers to presence of any retinopathy and macula, but is commonly reserved for significant changes, particularly vision threatening edema and ischemia. Then a pre-proliferative diabetic retinopathy, in which the cotton wool spots is being formed. The pre-proliferative diabetic retinopathy manifests with cotton wool spots, venous changes, and intraretinal microvascular anomalies, and often deep retinal hemorrhages. PPDR indicate progressive retinal ischemia with the highest risk of progression to retinal neovascularization. So next is the PDR, which is a proliferative diabetic retinopathy, in which the new vessels are going to be formed. So when the new vessels are formed, this case of diabetes is now known as a PDR. PDR is characterized by new vascularization on or within one disc diameter of a disc or new vessels elsewhere in the fundus. So when the new vessels are formed around the disc at the disc, or one disc diameter around the disc, then it is known as new vessel disc. But if it is found elsewhere, it is known as new vessels elsewhere. So advanced diabetic disease is consist of three things. Number one is vitreous hemorrhage, they're going to be glaucoma, and next is going to be tractional retinal detachment. So if any of the thing is present, it is known as advanced diabetic eye disease, ADED. ADED is characterized by tractional retinal detachment, significant persistent vitreous hemorrhage, and neovascular glaucoma. So this is basically a advanced abbreviated early treatment diabetic retinopathy, classification of diabetic retinopathy. So first is basically non-proliferative diabetic retinopathy. It is divided into non-proliferative diabetic retinopathy and PDR. So the NPDR is further divided into very mild, mild, moderate, severe, and very severe. PDR is then divided into mild to moderate, high risk PDR, and then there is a advanced diabetic eye disease. So in a case of a very mild PDR, so if there is no diabetic retinopathy, you can review the patient annually after 12 months. If there is a very mild NPDR which consists of microaneurysms only, then a review is more present in 12 months also. If there is a mild any NPDR, any or of microaneurysms, retinal hemorrhages, exudates, cotton wool spot up to the level of moderate NPDR, no intraretinal microvascular anomalies or significant bleeding. So first we are going to discuss about the severe NPDR, then we are going to go backward towards the mild NPDR. So with the severe NPDR, there is a 4-to-1 rule. So 4-to-1 rule means if a patient is having a severe hemorrhages in all the four quadrants, if patient is having a venous bleeding in a two quadrants, if the patient is having IRMA, intravenous intraretinal microvascular abnormality in a one quadrant, it is known as a severe NPDR. If any one of those is present, it is known as a severe NPDR. If two or more are being present, then it is known as a very severe NPDR. And moderate NPDR is basically you just minus everything by one. So if there is a severe vitreous hemorrhage in three quadrants, if there is a significant bleeding in one quadrant, if there is a no IRMA is present, then it is known as a moderate NPDR. And anything which is up to this level is known as a mild NPDR. So any or all of the microorganism, retinal hemorrhages, exudate cotton wool spot up to the level of moderate MPDR, no intraretinal microvascular anomaly or significant bleeding. Review ranges from 6 to 12 months depending on the severity of the sign stability, systemic factors, and patient personal circumstances. So you just review it 6 to 12 months. So in the case of a moderate NPDR, they are going to be the severe hemorrhages more than ETDRS, standard photograph 2A, um, 20 in 1 to 3 quadrants or very mild edema. Significant bleeding can be present in no more than one quadrant. Cotton wool spots are commonly present. So review in approximately 6 months. Proliferative diabetic retinopathy in up to 26%. High risk PDR in up to 8% within a year. So what can you do is you can review in 6 months, and there is a risk that PDR develops in up to 26% and high risk PDR in up to 8% of the patient in a year, within a year. So if a patient is having a severe NPDR, it is having one or more severe hemorrhages in all 4 quadrants, significant bleeding in 2 or more quadrants, moderate edema in 1 or more quadrant. Review in 4 months, PDR in up to 50%, and high risk PDR in up to 15% within a year. So the same but in a double. So you review in 4 months, PDR is occurring in 50% and very high risk PDR in 15% within a year. Very severe NPDR, 2 or more of the criteria of the severe NPDR. Review in 2 to 3 months. High risk PDR within 45% within a year. So then there is a PDR which is a mild to moderate PDR and a high risk PDR. So same with that, we are going to go from backward. So you have to know what is high risk PDR and what is more mild to moderate PDR. So high risk PDR have a 3 criteria, which is known as a high risk PDR. So if the patient is having an NVDs and the NVDs is greater than 1/3 of the disc diameter, so this is a disc diameter and NVD is present almost up to 1/3 of this area, then it is known as greater than 1/3, then it is known as high risk PDR. And if there is any NVD which can be less than 1/3 but it is associated with vitreous hemorrhage, it is known as a high risk PDR. And if there is an NVE which is greater than half of the disc diameter, so almost half of the disc diameter with vitreous hemorrhage, it is known as a high risk PDR. And anything less than it is known as mild to moderate PDR. New vessels or at disc or new vessels elsewhere but extend insufficient to meet the high risk criteria. High risk PDR NVD greater than ETDRS, about 1/3 disc diameter NVD, any NVD with vitreous hemorrhage, NVE greater than half of the disc area with vitreous hemorrhage. So treatment considered according to the severity of the sign, stability, systemic factors, and patient personal circumstances, such as reliability of the attendance for review. If not treated, review in up to 2 months. So basically treatment is being considered, so you have been systemic factors are being considered and review can be done in up to 2 months. Treatment is advised in a case of a high risk PDR should be performed immediately when possible, and certainly same day if symptomatic presentation with a good retinal view. So treatment is mostly PRP is being done or intravitreal anti-VEGF being given. So advanced diabetic eye disease is the same as having a 3 criteria, having a vitreous hemorrhage. If it is having a neovascular glaucoma, it is having a tractional retinal detachment, then it is considered as an advanced diabetic eye disease. So that's it for the part 1. See you in the next lecture.